very few people know that even dermatology has emergencies. Erythroderma. Erythro means red and derma means skin. So basically it is red skin. But
Today we have with us Dr. Bhagavi Utmani, and who is a dermatology resident. So the topic what we decided for this session was erythroderma, or also called as a generalized exfoliative dermatitis. So yes, ma'am, over to you.
hi Rohan. Hi everyone. So I'm a dermatology final year resident, and as we had decided, the topic for today is erythroderma, which is actually a dermatological emergency. So very few people know that even dermatology has emergencies. And when Rohan asked me what type of dermatological emergencies do you get, I had very few to name actually. So we don't come across a lot of emergencies in dermatology per se, but yeah, few cases are there which are, to be managed in inpatient and attended as soon as possible. So one of that is erythroderma. So if you see the word erythroderma, erythro means red and derma means skin. So basically it is red skin. But then what happens is in erythroderma you get diffuse erythema, what is called in medical terms, which involves more than 90% of your body surface area, which presents with variable degree of staining as well. So as we discuss further, everybody will get to know why it is considered as an emergency. So what happens is erythroderma in itself is not a disorder or a disease of the skin. What happens is some underlying disorder is already present because of which you get erythroderma. So you can just say like it's an end result of some dermatological disease or disorder. So there are various other conditions which result into erythroderma. We'll come across that. Just to name a few, we can remember by a simple mnemonic like IDSCALP, IDSCALP. Not in order of frequency, just to remember it. The most common one. So you can remember for idiopathic, which is the most common. We don't know most of the time what the cause of erythroderma is, around 30% of the cases. You can also remember I for infections. So infections like herpes simplex, HIV, fungal infections like leukemia, cephalococcus calvet skin syndrome, they can also present as erythroderma. Coming to D, known as used for drugs. So many drugs will also land you up in erythroderma. Most commonly, antibiotics like penicillin, cephalosporin, vancomycin, anti-epileptic drugs, NSAIDs, they can also land you up in erythroderma. Again, not very common, but yeah, we do come across new cases. Coming to S, you can remember S for seborrheic dermatitis. Now, it can also be present in children and adults. So one of the few causes in children could be seborrheic dermatitis. Not very common, but can be present. P is for contact dermatitis. Again, not very, very common. Hardly, we have not come across contact dermatitis leading to erythroderma. Coming to A for atopic dermatitis, again, one condition which is very common in children. Not many go into erythroderma, but yeah, if you want to consider children who present to you with erythroderma, you can consider atopic dermatitis to be one of them. L is for lymphoma and leukemia. So as far as a dermatologist is concerned, it is usually Sézary syndrome, which is actually a leukemic variant of CTCL, that is cutaneous T-cell lymphoma. But other lymphomas like, organs like thyroid, gallbladder, these can also, esophageal lymphoma, they can also present as erythroderma. But generally, we have not come across those as well. And then last is C, which is the most important one for us, is psoriasis. So after idiopathic, if we know any cause of erythroderma, that is psoriasis. Psoriasis, pityriasis rubra, pilaris, these are a few conditions which will end up or can end up in erythroderma. So around 25 to 30% patients of psoriasis, like of erythroderma, are because of psoriasis. So, coming to basic pathology, why exactly psoriasis happens? So, it has to be because of some underlying dermatitis or some underlying inflammation. So, what happens is the expression of adhesion molecules on the keratinocytes increases because of whatever condition you have previously. And this interact, like this complex interplay of the adhesion molecules, being increased, the chemokines being increased, and leading to increase in the cytokines. Now, it can be Th1 or Th2 cytokines, depending on what disease it is. All this is going to result in dermal inflammation. Along with dermal inflammation, what happens is the epidermal proliferation also increases. So basically, epidermal proliferation is also again in turn going to, lead to many T lymphocytes being recruited at the area of inflammation. So it becomes a cycle, you can say. So basically, the mitotic rate is going to increase. Your skin is going to grow at a faster rate than what it usually does. And there is something known as transit time. So what happens is keratinocyte is basically just a cell which is present in the epidermis. Normally what happens is the keratinocyte is going to come from the basal layer of the epidermis to the superficial layer and be shed off. That is what normally happens. So if at all you come across dryness, which is common in all of us, that is just body's way of shedding the old keratinocytes out. So in disorders like psoriasis or even in erythroderma, if at all they land up into erythroderma or due to any cause, this transit time is going to decrease. Normal transit time is around 28 days, meaning it takes around 28 days for the keratinocyte to come to the superficial layer and be shed off finally. In psoriasis, it is reduced to as less as 4 days, meaning that keratinocyte is coming up and being shed off in just 4 days, maybe even more frequently in erythroderma. So this time decreases and your rate of growth of skin basically increases. So it is going to grow at a faster rate than what it usually does. So these keratinocytes being shed is macroscopically seen as scaling. So whatever scaling you're seeing is nothing but keratinocytes being shed at a very fast rate than it should actually. This is what happens in erythroderma. And the redness inflammation is because of the dermal inflammation, which is because of these, inflammation. So this is basically what happens in erythroderma. So how the patient is going to present to you is they'll have erythematous patches which are going to be very widespread, like it is spread in a matter of few hours to couple of days. They present with patches which are coalescing and producing diffuse erythema of most of your body parts. More than 90% of your body is going to be involved, which is soon going to be followed by pain, which is what we spoke about, what basically it is. Along with that, the patient most commonly is going to have pruritus. Now, pruritus is nothing but itching sensation, burning skin. All this is common with erythema. Along with that, there is some tightness of the skin that the patient complains of. The feeling of tightness of skin is something, glossiness or tightness of skin. So, because of constant itching, the few areas can turn lichenified, especially over the face and all. Your eyes can also, like the area around the eye, can also be involved. There can be eyelid swelling. There can be ectropion because of the stretching of the skin. There can be blepharitis, all of that. Also, your nails are going to show similar changes. Your skin shows, meaning it is going to the skin under your nail is going to increase at a faster rate, which is going to give rise to thicker nails, brittle nails, ultimately loss of nails, onycholitis. Ultimately, after a certain period of time, your hair will be shed. So, in simpler terms, if you want to understand what is happening here, all your body's nutrition, which is going to your hair and your nails. These are few organs which are unimportant to you, basically. In time of crisis, you don't require your hair or nails. You can always regrow them. What's happening is when your body is trying to fight something very serious here, which is the infection, which is going, all the nutrition which is going to your hair and skin is going to be, directed to those organs which need it right now. So loss of hair, loss of skin, loss of nails is something which is going to happen. Telos and effluvium, we call it, after a certain point of time. So this becomes the cutaneous manifestation of erythroderma. The patient is going to be clinically constitutionally unwell. They'll present with fever, chills, malaise, generalized weakness, loss of appetite, all of that. More sometimes fever can be there because of some infective etiology. Sometimes the patient more often presents with a feeling of fever, like the patient is feeling feverish. Now, this is again because there is a little temperature dysregulation. Now, we are going into some discussion which is going to tell us why it is an emergency erythroderma. So what happens is the blood flow in your skin has increased due to vasodilatation of the peripheral vessels. So if the blood flow in the skin has increased, it is going to lead to heat loss from the skin, leading to hypothermia. So because of this hypothermia, what your body is going to increase your basal metabolic rate, which is going to try to maintain all the heat, ultimately resulting in a feeling of fever that is hyperpyrexia. So something like that is going to happen. Then, if it becomes more serious, then more systemic involvement can happen. There can be hepatosplenomegaly. There can be lymphadenopathy. Now, this lymphadenopathy can either be reactive or it can be in association with the malignancy that I spoke about earlier, Sézary syndrome and CTCS. So this can be there. Along with that, there is also going to be loss of fluid from your body, which can lead to hypovolemia. There is going to be a loss of proteins. This is really important because a lot of protein is going to be lost with all the scaling that is being, you know, uh, shedded, all the keratinocytes being shedded from your body. So that is very important. So that is all regarding the presentation of the patient. What we are supposed to do is just to treat erythroderma is it's not going to be enough. We can initially manage it, but unless and until we know the underlying disease which has caused erythroderma, all this initial management is going to go in vain. It is not going to come handy in a long run. We ultimately need to find out. So, yeah, few clinical findings which can probably help us to find the underlying causes is the kind of lesions that we are coming across. In case there is some blistering that we find, we can probably, it could be because of pemphigus foliaceus. I think I forgot to talk about that in the etiology. Many of the immunobullous disorders like pemphigus foliaceus, bullous pemphigoid can also present with erythroderma. So if you find blistering, that can be one of the leading points towards that. In case we find fine flaky scales, it could be probably atopic dermatitis. In case of like silvery white scales, probably it goes in favor of psoriasis. In case we find thick, greasy scales, yellowish, greasy scales, mainly over the seborrheic areas, it could be because of seborrheic dermatitis. So these are just a few pointers. In case we come across few findings like this, we ultimately, end up diagnosing what the patient had prior to developing erythroderma. So one of the other things that we can do is dermoscopy. So dermoscope is nothing but a handheld device. It's just like an ophthalmoscope. Dermoscope is going to help us see the micro features on the skin, which can vary from disease to disease, ultimately helping us in diagnosing what it actually was before. So I'll just talk about the common one. In case of psoriasis, in dermoscopy, we'll see red dots, which are nothing but it corresponds to the dilated blood vessels in the dermis. Along with that, silvery white non-adherent scaling can be there, red structureless area can be there. So this is one non-invasive method by which we can probably, get to the diagnosis. Histopathology, now skin biopsy being sent for histopathology, it will help you only when you have some typical lesion of the prior condition. In case you're sending biopsy from the area of erythroderma, you're going to end up finding very non-specific features like acanthoma, hyperkeratosis, parakeratosis, and dermal infiltrate of inflammatory cells. So it may or may not come handy sending the patient in for histopathological exam. So coming to evaluation, how we evaluate a patient of erythroderma. So this is to actually know the general condition of this patient as well as to, decide the further management. We need to evaluate whether we are dealing with only the skin manifestations or there is something going on inside as well. including few other systems as well. So we'll just do the basic routine investigations like complete hemogram. In that, we'll see non-specific findings like anemia, leukocytosis, increase in ESR and CRP. We also need to look for liver and renal function tests because low proteins, low albumin. Also, liver, if it's affected, then the enzymes will be high. All of that. Urine, we may find some focus of infection, urine routine, RPS. After all these basic investigations are done, you decide what you want to start the patient on. Before that, we are going to do an initial management. So initially, the patient has to be ideally admitted under dermatology ICU to maintain an ambient temperature because there is going to be a lot of temperature dysregulation. So an ambient temperature of around 30 to 32 degrees Celsius is to be maintained. Along with that, we need to replace the fluid and all the nutrients that the patient has lost. So we should always encourage the patient to take orally as much as possible. So this is going to help the patient maintain all the gut flora. In case the patient is not taking orally, then we can always go for parenteral nutrition. Along with that, electrolytes are to be corrected in case that is imbalanced. And for the cutaneous manifestations, we can start the patient on topical corticosteroids or emollients. Now, emollients are nothing but it's a type of moisturizer. So we need to repair the skin barrier. So skin is the first thing that comes in contact with the environment. Like anything hits on you, the skin is the first line of defense. So that barrier is basically broken or damaged right now. So that has to be maintained. And topical corticosteroids will take care of the inflammation and even the itching part. If not, oral antihistamines, all the symptomatic treatment is started for the patient. Along with that, we need to rule out whether it's drug related. So all the drugs the patient is already taking needs to be stopped. If it is life saving, not in that case, but all the non-essential drugs are to be stopped at that point of time. So this is the initial management that we do. After that comes the specific management. So depending on the underlying cause of erythroderma, we'll decide on what needs to be started. So in case it is idiopathic, then we'll keep the patient on topical corticosteroids, emollients, and symptomatic treatment and see for the response. If they don't respond, if the cases are refractory, then we think of starting them on systemic corticosteroids. If it is psoriasis, which we have commonly come across being a cause of erythroderma, then we can start the patient on either the methotrexate or acitretin or cyclosporin. Now, cyclosporin we have in our ICD personally preferred because it's a really fast-acting drug because it acts on all the cells of the cell cycle, all the phases of the cell cycle. It's a non-cell specific, non-phase specific inhibitor. It acts on all the phases of the cell cycle. So it's going to act really fast and it's going to decrease the inflammation. It inhibits the T lymphocytes, which are coming into play in erythroderma. And it is also going to inhibit the NFAT, which is nuclear factor of activated T cells, decreasing the interleukin 2 and interleukin 2 receptors. So basically, the pathology of erythroderma, it is going to take care of that really well. Topical corticosteroids in psoriasis is fine, but we generally avoid systemic corticosteroids in case of psoriasis because traditionally the dermatologists are being taught that in case of withdrawal of steroids, oral steroids, in cases of psoriasis, or even reduction of dosage, after a certain dosage, there can be a flare of psoriasis. So if the patient is in erythroderma, we don't want the patient to, have one more flare. So it's not that we have never given patients oral cortico or IV corticosteroids, but it is to be avoided, not as first line, definitely. We might have tried all the first line and second line drugs, and if the patient has not responded, then we may have started with systemic corticosteroids. So all the points that I discussed of being as an etiological factor for erythroderma, all those things are to be managed specifically. In case of atopic dermatitis, oral or topical corticosteroids are fine. So it depends on the underlying disease actually, how it is to be managed. And ultimately, the mortality is very variable. So it is like 4 to 64%, depending on the individual's age. So if it is an old patient who's already comorbid, then the risk factor increases of developing complications. So common complications would be development of secondary infections, going into septicemia, developing high output cardiac failures because of the vasodilatation that has happened. Uh, One of the complications. So these are a few complications, and the patient you never know when the patient is going to progress to that. So all these cases of erythroderma, even though the textbook says that mild cases can be managed on an outpatient basis, but we would definitely not recommend. We would always recommend admission and IPD care for the patient. So, mm,
Okay, ma'am, we have some questions regarding the topic.
yeah.
Yeah, the first question we already answered this question, but the other question is: are you in favor of prescribing the systemic corticosteroids in all patients of erythroderma? So basically, my question has been changed. Like, if there is a idiopathic patient coming to you, you don't know the cause. So you will start
Correct.
with the systemic or just first topical, then systemic.
If we are not able to find any cause, then systemic corticosteroids would not be my first option. As I told you, we initially manage the patient with some general measures and then topically and symptomatic treatment for the itching. All that will be started first. And based on the response, we'll decide whether to start systemic corticosteroids. That is not going to be probably my first choice. After all this, if the patient is not showing any response, and also the investigations and the basic evaluation is to be considered, like whether the patient has systemic involvement or whether the patient is stable but just has cutaneous manifestation. So all these factors come into play, especially idiopathic. But then idiopathic, you may go for that, but there are few conditions where it is not definitely not the first, right? Like the one I told you, psoriasis is definitely not the first.
The next question what we have is, ma'am, what is the relation between the cytokine storm and erythroderma?
Okay. So as I explained in the pathology, this is a complex interplay of chemokines, cytokines, and all the other inflammatory mediators like TNF alpha, interferon. All that is going to come into play, and it is going to basically recruit the T lymphocytes as well as the Langerhans cells to the site of inflammation. So it becomes like a cycle. So because of that underlying disorder which you already had, the cytokine storm which is being produced is going to go into a cycle of inflammation, more cytokine storm, more inflammatory mediators, again causing inflammation. So it has a direct relation.
Next we have, ma'am, how much protein supplement you will give for a patient for this? As protein will be lost in this phase, so how much protein supplementation can be?
Yeah, there is a very high level of protein which can be lost in the scaling. As I told you, it is as much as 9 gram per meter square of your body surface area which is being lost. So initially, we'll obviously assess the protein levels and the albumin levels of the patient. Even we could also infuse the patient with human albumin infusion. But on a dietary basis, we'll advise the patient to take at least 2 to 3 grams per kg of protein initially. And then we'll keep reassessing. Like it's not like there is a fixed duration of until what we ask the patient to take this recommended uh, amount, but we keep investigating the patient and keep seeing the improvement. But initially, it has to be around 2 to 3. For normal individuals, we have 1 gram per kg. But then in these patients, we have a little higher daily recommendation.
That's what we have is, as per the data, what we have seen, it's a age more than 40 years. Normally, what we have seen, there are pediatric patients, but yeah,
Yeah, correct.
so there's a relation between the age and the disease.
So there is actually not a direct relation between age of the patient and the patient being in erythroderma. Maybe it's just that the conditions which go into erythroderma, there are fewer cases which are more commonly seen in children going into erythroderma. Like if any child is going into erythroderma, there are few conditions which you will suspect first rather than the others. So actually, there is no age-related direct relation that kids cannot go into erythroderma or this age group is more susceptible to erythroderma. It's not like that. It's mainly just the incident.
Maybe because of medication, what we take after 40 years and all, or psoriasis and all
Yeah,
that
correct.
happens.
Like medication. Yeah, it could be medication. And if it is a child, erythrodermic form of psoriasis can be present in children, but then erythrodermic forms of psoriasis in children, that becomes a little rare. So as such, there is no direct relation, but conditions which progress into erythroderma, which are common in kids, that is a little less.
That's what we have is, so what is the main cause of the mortality in these conditions?
So the main cause, I think I had already, the patient will go into secondary infection. If they are not treated, they can progress into having some secondary infection, ultimately septicemia. Also because of the coexistent electrolyte imbalance if they are not corrected. But heart failure is also one of the common causes of mortality, along with ARDS, pneumonia and ARDS. So these are a few common conditions. But then most commonly based on like personal experience, what we have seen, septicemia, a septic shock.
Well, last question what we have is, what is vancomycin infusion reaction and how can we prevent that?
Okay. So vancomycin reaction is also known as red man reaction. Vancomycin actually gives rise to two kinds of reaction. One is the red man reaction and one is the anaphylaxis. So what happens in red man reaction is initially like the old school of thought was that because of few impurities which are present in the vancomycin infusion, maybe because of that this reaction was happening. But even after they purified the content, it was still they were still coming across this kind of reaction. So the current school of thought is it is because of the rapid infusion of vancomycin that this reaction takes place. So what happens is you will develop redness more commonly over your face, upper trunk, neck area, your upper body, along with a lot of itching. So this happens most commonly in first infusion of vancomycin. Like it can either start from 5 to 10 minutes into the infusion, or it can even start as soon as you end with the infusion. So it can be even as late as the end of infusion. So this are the cutaneous manifestations. Systemic could be dizziness, headache, hypotension, anaphylaxis if it progresses. So how you can prevent it is you can before infusing vancomycin, we can give the patient oral antihistamine, either hydroxyzine or diphenhydramine. We can give the patient that before infusing vancomycin, and also uh, the infusion rate is to be considered here. So 1 gram of vancomycin has to go over a minimum of 1 hour, not lesser than that, because most of the reactions we come across is because of rapid infusion, which are less than 1 hour. So both these things, if at all we want to combine it with some H2 blocker, like H1 and H2 blocker, cimetidine can also be given. And if the patient is already in reaction, we can give one IV diphenhydramine, which is an antihistamine, along with stopping the infusion immediately. And once the patient is stable, maybe restart at a slower rate. So this can be done.
Okay, coming to the end of the session, and thank you, ma'am, for joining and inviting us for this session. Thank you so much.
Thank you so much for having me.
Thank you.